Clinician Scientist interview. And today we have Dr. Sylvester Black, who is a transplant surgeon, as well as the director of OSU Surgery for Center and Research, and much more. So join us for our conversation to get to know him a little better, his career journey, and what he's doing right now. So Dr. Black, the great Quinn Capers, who's now no longer with us, posted this picture of you and him, who look like twins, by the way.
Yeah.
And he mentioned, you had just gotten an R1.
Sure.
And we felt like that image and that brotherly love, it seemed like a culmination of many years of work.
Yeah.
Tell us a little bit about that,
Well,
how you were feeling.
Quinn's a great friend and a superb advocate for African American physicians as a whole. And it was great to be recognized by a friend and colleague like Quinn after many years of work. When I started my journey here almost a decade ago, it came from almost nothing. I mean, when I got my lab, there was very little equipment. Most equipment we found in hallways. We had to cobble together money however we could. And to see that, with many years of hard work, that you can get to where you're sitting on study sections and you're getting very prestigious grants, it really is, it's really excellent. And it really does lead to that feeling of accomplishment, like you've kind of arrived. And so Quinn was just fabulous in that regard.
Awesome. So definitely, we all know R1s are pretty prestigious.
Sure.
Tell us a little bit about your journey to here. Were you a first-gen college student?
So I'm not a first-gen college student. Both my parents went to college. My mother got her master's in social work, and my grandmother actually went to college and was a teacher. So we have a long line of people that have gotten education, and have a lot of teachers in my family, and they passed that on to me, and I'm here teaching the students and residents and fellows at Ohio State.
Awesome. So, in your path to medicine, did you always know you would end up here?
As a surgeon?
Yes.
I've always wanted to be a surgeon. I mean, I actually wanted to be a surgeon before I really understood what a surgeon was. And I can look back to when my mother was getting her graduate degree in social work, her master's degree, and she would we didn't have much in the way of childcare back then, and she would kind of take me to the library when I was 7 or 8 years old. And we would sit in this medical library, and she'd go off and do her thing, and I was left with these piles of books, and I started going through them, couldn't understand the science, but definitely really got into the medical history and all these, so I was allowed to check out all these books, and my mother would bring home stacks of library books, and I would read them at home and go through the pictures and just really got immersed into it, and surgery was just fascinating. I mean, the whole idea of actually operating on somebody was immense. It was an immensely powerful idea to me. And then, I wouldn't bring the library books back. My mother would rack up all these library fees, and, I'm probably going to go to jail if anybody sees this. But, it really got my start, my exposure to medicine and my exposure to surgery.
So you mentioned you kind of sort of had the feel for surgery and
Sure,
medicine.
sure.
What was research?
Research didn't come into it until a little bit later, to be honest with you. I was just getting my feet wet, kind of understanding what medicine was. But really, I did have an itch to do the research and the science. Back even when I was younger, I always excelled and liked science. But I realized, when I was in medical school that, with an operation, I can help one patient, one at a time. I take care of my patient on the operating room table. But with the research, the potential is there to help thousands, tens of thousands, maybe even millions. The impact is so incredible when you can blend it with the clinical side of things. And that really, and I like problems. I like solving difficult things. And so the research allows me to go and tinker in my laboratory and then come back and take what I find to the patient. And that's really where research is powerful.
Definitely. I think we all have the same itch when it comes to knowing that research can help us treat more patients, right? Populations instead of one patient. Okay. So your earlier streams definitely involved medicine and surgery. Research kind of sort of came after. And so now you're sitting here, you're the director of OSU Surgery Center for Research.
The CREATE Center?
Yes.
Mm-hmm.
What does that mean for you?
So the CREATE Center is an interesting construct because it's a center within the Department of Surgery whose job it is to foster intellectual curiosity, it's to foster intellectual development, it's to foster innovation. It's really an innovation center. And so, as surgeons and as clinicians, we're very busy treating our patients, most of us, and most of the faculty at most academic medical centers. And they get caught up doing that, and they have a lot of great ideas on how they can help patients. And sometimes those ideas stay in your head. They don't go anywhere. That you can't translate that to helping patients. And so what the CREATE Center's whole mission is to allow faculty members to provide them with a path, an area to translate those findings and those things that they have, and to get those ideas to treat the patients, back to the patients, the bench to bedside idea. I had to learn a lot of that stuff the hard way. I had to learn a lot of that stuff on my own. And we've had some success. We've submitted patents. We've got some intellectual property from it. We've developed some therapies that we hope, with my laboratory, can help patients. And so we wanted to take that with the support of the Department of Surgery and help other physician scientists do the same. And I think with that, we can have a very impactful department and institution.
So is it like most programs that I know people are applying for residency are like
Sure.
PSTP, so something
Sure.
like that.
Mhm.
That's awesome. Perfect. So in your role, what do you kind of sort of hope to accomplish with CREATE Center?
So what I would like to do is, one, increase the intellectual property that comes out of the Department of Surgery and the medical center as a whole, where we take some of these ideas and that we can patent them and then actually develop therapies to help patients. Two, I would like to also develop a center that's nationally known for helping to train and educate people, whether it's on the newest and latest techniques, whether it's partnerships with, say, business schools to look at the entrepreneurial aspects of medicine, and to develop people and allow the faculty to have pathways in which to take these ideas that they may have and show them a way in which they can actually develop those ideas and provide them with the tools. Oftentimes it's hard to really get a handle on what tools are available in an institution, and so we, with the CREATE Center, would like to enable that to happen for faculty members.
So you decided to get an MD PhD. Can you tell us how you sought out the PhD?
So my path's a little bit different. And so most people that get MD PhDs do it in one of two ways. Sometimes people will get the PhD first and then decide they want to be a physician and go to medical school. The most common way that people get MD PhDs is to go in a combined program and do the MD PhD at the same time. For me, I thought about it, but I just decided to get the MD first. And when I was at Northwestern, I did that. But I was very, very interested in the PhD. And I worked as a medical school in the laboratory of John Fryer at Northwestern, and he was as a transplant surgeon, a physician scientist who ran a lab, and I got to follow him around and see what he did during the day, operating on patients, and follow him into the laboratory and see what he did. And he was a very bright and intelligent individual. And I said, this is really cool, that you can tackle these very hard problems. And he was just such a bright individual, and I was like, I want to be just like that guy. And so really I thought, well, how am I going to get my PhD? I've got my MD. I'm mostly through the medical school. How do I do this? And John says, that's very simple. Go to University of Minnesota. And the University of Minnesota was unique in that time, where they actually train surgeon scientists, and you would go through the first few years of your residency, and then you would take time off to go to graduate school and get your PhD, and it's generally about 4 years, and then you would complete the last 3 years of your residency. Now, it's a long road, and it was a very, Minnesota has a track record of training these people across the country, a lot of the leaders in academic surgery. And so I got into the University of Minnesota, and I spent 9 years there. I was able to go to the graduate school, and then I got funding. I got my first NIH grant when I was my very first year out, my National Service Research Award, and then the love continued from there.
Awesome. What would you say is the difference between the traditional MD PhD and your path? And what did you get from your path that you think is unique compared to doing it together?
Well, initially, they both have their merits, and I would say that the most common way is to do it together, and that's a very good way. You're learning the basic science at the same time you're in your medical school classes, and it kind of just blends very nicely. When you did it the way that I did it, you kind of have to go back and you have to kind of catch up and learn that. And you're sitting in graduate school class with people that are a lot younger than you, and it was an experience. But I was I knew what I wanted to do at that point. I think I was more mature in my journey. I actually knew the impact that I wanted to make, having been in the clinic, been on the wards, dealing with the patients, and I had ideas about the impact that I wanted to make. So it was very easy for me to look back and enroll in my PhD and then kind of see the impact and really have a very precise kind of plan of study. And Minnesota was very good like that.
So, that's good to know. What about liver transplant, right? When you're a transplant surgeon, you can transplant any organ you want.
Sure.
Why the liver?
So liver transplantation for me wasn't the first thing that I wanted to do. Now, when I went to medical school, I wanted to be a heart surgeon. I was very interested in heart surgery. I mean, the heart is a very romantic organ in a lot of sense, and so and you kind of like the way the heart surgeons kind of walked around. And the more I got into it, and I liked it a lot, but the liver was an interesting organ, right? We still don't understand the functions of the liver completely. It does so many things. It's one of the only organs that if you don't have it, there's nothing you can do but get another one. There's no machine, there's no medicine, there's nothing that can take over the function of the liver. And I like really hard things, and liver transplant is really difficult. I mean, it's a really difficult thing, both scientifically to approach the liver and even medically and operative-wise. I mean, the liver transplant is among the most technically challenging of all the transplants to do. But when you see a patient that's at death's door, in 1 minute, you take them into the operating room, and 4 to 5 hours later, you have a patient that's going to walk out in 10 days and live another 20 to 30 years. There's very few things in medicine that can have that dramatic impact. And the liver, it's the only organ in the body that regenerates. I mean, how does it do that? I mean, there's so many things. It seems like there's a lot of scientific runway with the liver that may not necessarily be present in all aspects. And so that attracted me to that field of study.
Awesome. So this is a side question because now I just remembered. My first time here, I worked in a lab, and we were coming to the lab for the heart, and you were there for the liver, and you, I think there's another person on the table to get it, and you walked in, you're like, hey, we've been waiting for this liver, and you came in, and they had to move the table up. Right? And I was like, oh wow, that's awesome, right? You became the person who were at the table. Like, describe how it feels like being in an operating room for you each day, and what does that mean for you?
The operating room is one of the most enjoyable things that I do. I mean, it's almost, sometimes I go into the operating room, I'm thinking, I get paid to do this? I do this for free. Don't tell anybody that. But it's the truth. I mean, you go in there and you can, I have a problem with instant gratification. I really like to see the progress of the things that I do. And so when I go into the operating room, there's an immediate fix there. It's a technically challenging problem. You fix it, and you see the immediate result and the immediate impact. And it's a lot of fun. And it gives you time to think three-dimensionally, think critically, solve a complex physiologic problem, and then get immediate results. And so, a lot of the surgeons are very much adrenaline junkies. We like that kind of situation. We're very much, kind of into the moment. And that's why I like liver transplant. That's why I like surgery. That's why I love the operating room.
So what does it mean to you, that process of taking an organ from someone else, a donor, and giving it, giving pretty much a life to another?
So transplant surgery is unique in that it's very multifactorial. You have to multifactorial. You have to consider a lot of different aspects. You have to consider the donor and the quality of the donor organ. And is that donor going to help the recipient that you chose or some other recipient somewhere else? And it brings those two things together. And one of the things that you have to be very, very thoughtful about when you do a transplant operation is that if this organ doesn't work, then you've doomed the patient, you've doomed the recipient. And so you have to factor all those things together. And if there's some reason that you can't use that organ, then you shouldn't use it and hurt the patient. And my research is for trying to make organs make repair organs in a sense, and we'll probably talk about that a little bit later. But a lot of these organs get thrown away; they don't get used, and we can repair those organs.
So, Dr. Black, tell me a little bit about the challenges you've experienced as a Black man in medicine in science.
So that's a very good question. As far as challenges, when you think about the challenges of life, that you've had as an African American male in particular, just living your everyday life, those get magnified and kind of focused as a attending and as a surgeon and as a scientist. There's the disparity, I think, actually gets magnified. I mean, the further you go, the less and less you see of African American physician scientists. There's going to be, there are certainly challenges in terms of people thinking you can do it. There's a lot of people tell you what you can do. They put limitations on you. They say, well, you can't do this, you can't do that. And you have to be able to tune that stuff out. And you have to be very focused and you have to be able to get back up when you get knocked down. I think about the times when I've submitted grants, and they fail. I mean, they fail more than they succeed by a lot. And so, you may turn in 9 grants and get 1. And so you have to you have to really build up some resiliency. And the living as an African American, you have that resiliency naturally. I think that you're well prepared for a career in science, in my opinion, and it's certainly something. It's been a journey.
Thanks for sharing that. So you recently also did a promo video
Sure.
for your department, and you talked about being a victim of your own success.
Sure.
Right? In the way that you now have more patients needing organs than organs for patients. Tell us a little bit about how does the Copper Lab, how are you guys working towards making sure every organ is being used?
So transplantation, in the 1960s, if you were going to have a transplant, there was 100% mortality. You just didn't survive for the most part. It was very experimental. The real heroes of that were the patients that went through it because there was no chance of survival. And we got better in the 1970s. We got cyclosporin and we figured out how to do the operations. In the 1980s, we refined it and patients were starting to survive, and you're starting to see more year survivals, 2-year survivals. And then in the 1990s and 2000s, we really improved our craft quite a bit. And then you were starting to get 90 and 95% survivals, patients living 10, 20, 30 years past that point. So it's really, transplant has really been one of the modern success stories in medicine, modern miracles. It's one of the only areas in medicine where you can take 100% fatal illness and get close to 100% survival if you can get the right organ and kind of master the techniques, as which we've done, and then you get a significant patient survival. So that's interesting. But however, we're a victim of our own success because now we can apply this therapy broadly. There's more people that can benefit from transplant than organs that are available. And it's not, people die and there's a nut, you would look at it and you say it doesn't make a lot of sense because the number of people die easily outnumbers the number of people that are on the waiting list. However, people have to die in a very specific way or the organs become damaged and unusable. And so what happens is that many people die on the waiting list without donor organs. And so we've mastered the surgery, we've mastered transplantation as a field, but we can't save everybody that needs to be saved because we don't have enough donor organs. So the Copper Lab, and it stands for the Collaboration for Organ Perfusion, Protection, Engineering, and Regeneration. Our goal is to take these organs that are too damaged for transplant, that are otherwise being discarded, and repair them on a cellular and a molecular level, such as one would repair an engine in a car or repair an electronic device. We can take these organs out, we can put them into these kind of miniature ICU or intensive care unit machine type environments and keep them alive outside of the body. And with that, we can assess their function. We can look to see if there's anything that isn't functioning the way that we want, and we can actually repair them. And our laboratory develops a lot of these novel therapies and small molecular inhibitors and small molecular repair proteins that can repair these cells of the donor organ and make them transplantable. And so that's really a novel concept. It's an interesting concept. It was a concept that actually came about in the 1930s. And it was forgotten because we didn't have the science at that time to be able to do it. But now with all the molecular biology and the genetics and all the things that we can do, we actually can do some really cool things.
Awesome. Has any of these organs that you guys repaired been transplanted into patients?
So right now we're at the area that we are doing clinical trials with the devices to keep the organs alive outside of the body. Right now, most of our work is confined to animals. But in the animals, it's incredible. And the NIH and Department of Defense and some other agencies have funded our work because I think the work has a lot of promise. That said, you have to go through FDA trials. Taking a drug from kind of concept to actually being able to use it in a human is a pretty long and daunting process, but we're up for it.
Awesome. So tell our audience a little bit about that timeline, because a lot of us think, we develop this awesome thing
Sure.
and immediately it needs to be get into patients.
Well, it's interesting. I tend to think, and this is kind of a little bit to think about a little bit in terms of a career in science, right? In clinical medicine, 95% of what we do works, right? So we treat a patient, we operate on them, we give them medication, and 95% of the time or 90% of the time, we get a good outcome. In science, in the 5% of the time, we fail. In science, it's the exact opposite. You are successful 5% of the time, and you fail 95% of the time. And if you look at developing and taking therapies and actually translating them to the patient, there are more failures than there are successes. And so you may have an idea, and then you get this idea, and you run a bunch of experiments in the laboratory, and you get some pilot experiments and some data. You write a couple papers, and then you apply for grants. And most likely, most of the time, those grants will not be funded initially. You develop and refine your idea, and then you keep applying for grants, and then one day you get a grant, and then you take that and you publish more and you refine the idea more, and then other laboratories repeat your work, and then you develop therapies and things like that, and then you've got to find somebody interested in taking that to the next level in terms of clinical trials and being able to do experiments outside of animal work. And then you have to find usually some company or some entity that has significant money, because drugs and therapies are millions and sometimes billions of dollars in terms of the R&D that goes into them. And very few, probably less than 1% of those things actually become something that gets used in patients. And so it's daunting, but it's fun.
Absolutely. Are there any promising areas of study in your lab currently? And in the next 5 to 10 years, what really excites you about this field of research?
Well, transplantation is going to change in the next 5 to 10 years. Now, everything we do is we go out and we'll procure an organ, usually in the middle of the night, from a donor. We'll put it in a bucket of ice, and then we'll transport it across the country and implant it in a patient. Many things are very rushed, and it's very, there's a lot of urgency to it. The future transplant, I think, is going to change, and it's going to change in very kind of unique and interesting ways. I think that we'll put these organs on these machines and keep them alive, and it will be more of an elective procedure performed during the daylight hours. We'll be able to assess the organ and perfectly match it with the recipient. We'll be able to fix organs that aren't functioning well and make them function incredibly well. Some of the therapies, and you've heard of things like CRISPR and gene editing and all those things. The future, and what I think is really the kind of cool part about all this, is we actually will be able to modify and change those organs on the genetic level. And so we can make a heart that once wasn't yours, at least according to the immune system in your body. And there may be a day when transplant patients aren't taking immunosuppression. You could see a day when, if you had heart disease and instead of getting that coronary artery bypass, you would just get a heart transplant with a heart that was functionally and genetically very similar to yours, and you wouldn't have to worry about taking immunosuppression. So that's really cool, and those are the things that kind of I see in the next 10 to 15 years.
Awesome, excited for that. Hope to be a part of that as well, especially with the heart. So, why is your research? What would you say to a layperson or a high school student, undergraduate student thinking about pursuing this path?
Sure.
What would you say is really important about the research that you're doing and the kind of patient population that you're trying to help?
So there are no therapies that are cures for end-stage organ disease. There just aren't. I mean, you can have dialysis if you don't have your kidneys. You can put in artificial hearts and kind of get by with some of the heart disease with the liver. There's pretty much nothing you can do. Lungs the same. So the concept, and this is kind of the audacity of transplantation, the ability to take parts from a person that have died and put it in another person and get perfect or close to perfect function, and they can go on and live their lives normally, is really interesting and really cool and really neat. And so that's one of the allures of transplant. It's not perfect yet, and a lot of us in the laboratory are trying to get it as close to perfect as we can. And that's where the research comes in and some of the things that we were talking about a little bit earlier.
So most MD PhDs enter into internal medicine or other non-surgical specialties, right? There's no emphasis on the surgeon scientist, which is who you are. What are the benefits and downsides of being a surgeon scientist compared to going into internal medicine and probably being an immunologist?
Surgeon scientists are a rare breed nowadays, and they're becoming rarer and rarer. A lot of the clinician scientists the early ones were surgeon scientists. It was very easy to kind of, the operating room was your laboratory, and the morgue was also your laboratory, and you went back and forth, and you were able to translate your findings easily, in the past. As medicine has changed, and there's been more of a push to accounting and the bottom line, and we have to be honest that it is a business. The surgeons have kind of become more and more technical, and they've been pushed in that direction for a lot of reasons. And now, there is some emphasis, so we see that we don't have many surgeon scientists left. And so there are a number of task force. I know I'm part of one for the American Society of Transplant Surgeons to figure out how to increase the pipeline of surgeon scientists. Because surgeons are creative people. I mean, we oftentimes will be in the OR and we'll have to think of non-textbook solutions. We'll have to kind of think of things three-dimensionally in our head and immediately have to translate what's in our head to our hands and to the patient. And so surgeons are very creative individuals who have they're elbows deep in disease, so to speak. And so I think that it would be a real loss, and it's a tragic loss, that there are not many of us left. And so, one of my, hopes, even with the CREATE Center too, is to help kind of foster, the surgeon scientists, because I think that they have an important role to play in scientific discourse.
Agreed. So to that same statement, the idea that the MD PhD path is already, 8 years.
Yep.
And if you take the route you have,
sure,
that's,
longer.
Even longer. So on top of that, so let's just take the traditional MD PhD path. You do 8 years.
Sure.
And then if you do decide to take, become a surgeon scientist, you usually have to do internal medicine and then go specialize into something else. And I know there are programs recently that are trying to mix the two. We talked about PSDP programs. So the length of that training for, I think that's the thing that most people are shying away from becoming a surgeon scientist. What do you think that, we can do as leadership to change that path to make it more attractive?
Well, my advice to people, because people oftentimes, even with surgery residency as a whole, shy away from it because the training is long. We think, well, I want to get out there and start practicing. I don't look at medicine as a job. It is a career, it is a lifestyle, and you're going to be doing it until you retire. So whether you're in training for a few additional years or you're out practicing, it's irrelevant compared to an entire career. The training is important because some of the things that we're tackling are very difficult and you need that long training. I've never regretted it, and I do agree that it's long. However, a lot of people are going into it not really understanding, they look at it from the outside. This is from somebody that's done it and has spent a tremendous amount of time in training. The days are long and the years are short. And I can remember when I was in the chair, just like you are right there, and I remember all those things. And, I think that just, if it's your passion, if it's something you love, if it's something that you're curious about, time's gonna fly. If you love what you're doing, it doesn't matter how long you train. If you hate what you're doing, you can train for 12 months and it will feel like an eternity. So I would say I would say to all trainees, don't focus on the time of training. Look at it as an entire career.
Awesome. Thank you. So, surgeon scientist or MD PhD, no matter how you put it, usually there's a balance, right?
Mm-hmm.
How much time you're spending doing research versus the actual practice of medicine. The general consensus is 75% research, 25% practice. What does it look like for you?
So everybody tries to put a number on things. I mean, this is whether you're the NIH or you're, the chairman of surgery or you're some other administrator in the organization. Here's a fact about surgeon scientists. We just do both. We don't really calculate what the time is, 75%, 25%. I'm there at night, I'm on the weekends. I operate in the middle of the night. I work in the day. I mean, I would say that my research, I don't distinguish between my research and my clinical care. I meld the two. When I have a problem or I'm thinking about a problem with a patient, I'll go in the lab and work on it, then I'll go back and take care of the patients. And I would say I don't, if you're looking at a 70 you're looking at a 40-hour work week or an 80, more like an 80 or 100-hour work week as a surgeon, I would say for me it's about 50-50. Although on paper I'm 70-30, but that's not real. I mean, I do a lot of research.
Awesome. I think that's important for our audience to hear, right? Because we hear the 75-25 and really don't know what that really means.
I think it's one of the things, I think it's one of the things that's kind of it's used against the whole idea of being a surgeon scientist, that you can't be a good technical surgeon if you're doing research 75% of the time. And that's simply not true, because namely nobody does that. No surgeon scientists I know, they all operate and they all do surgery and they all do research.
Good. So you've told me all of that. What keeps you motivated in this process?
I want to make an impact. I want to, I'm really interested in, when I'm done with all of this, what does medicine look like? Will medicine know or care that I practice in that field? And not just the patients that I've treated, but the patients that will be treated by the people that I've trained. The therapies that, the way that we look at disease, will it be different by the time that I'm done? And what kind of impact can I make? How good can I be? What are some of the changes that I can make in the field? And that's what keeps me going. I want to look back and say, I remember when we used to do it this way, and now I can't believe we're doing this. We're operating with robots. I mean, whoever thought we'd be operating with robots? I mean, that's ridiculous. I mean, look what's happening now. And that's I want to make an impact, and to make an impact is why we're doing this, or why I'm doing this.
Perfect. So pretty much Dr. Black wants his name on a building.
No, I actually don't even care about that. But I want to know that when I look back on a disease, that you can feel good that your career made a difference. Like not just with the patients, but even the whole idea of treating disease. I mean, and so that's kind of why I do this. That's why I get up every morning. I get jazzed, thinking about those things.
That's awesome. I think that's what moves most of us as well. So you've done all of this, but you haven't done it alone, right?
Sure.
Who were the great mentors for Dr. Black?
So I've had a lot of mentors along the way. I can think of many of them. I mean, we talked about John Fryer earlier. Science-wise, Gus Del Maso was the person that I got my PhD under him. He's an immunobiologist at Minnesota, and taught me a lot of what I know about science. The mentors that I've had, at the University of Minnesota, I think about Selwyn Vickers, and he's one of the other surgeon scientists, African American. He's the dean at UAB, and he's tremendous. And I owe a lot of what I am to him as well. I think about my mentors in Toronto, Paul Gregg, David Grant, Ian McGilvery, Mark Cottrell, all these people that taught me what it is to be a supreme clinician and master surgeon. And I really learned a lot from them. And then I look back here, when I have gotten here, and I look at Bob Higgins, who recruited me to the Ohio State University and believed in me and gave me an opportunity. All we want is an opportunity, and he was one of those individuals. And now he's at Hopkins, where he's the chairman. I've had a lot of mentors along the way. I think about my grandparents and my parents who wouldn't let me quit. And every day, all of us think about that. It'd be easier just to quit and do something else, right? And some of the people, the support system that you have, and the people in your life, and your mentors and your sponsors that don't let that happen. And I'm in large part here today because of that. Quinn Capers, of course. Love Quinn. Yeah.
Absolutely not. And so, what would you say is the greatest challenge that you had to overcome, or the greatest success, you choose, on this path to where you're sitting here right now?
I don't look at it as a single challenge, because life is a challenge. It's always that waking up and proving that you're good enough, not just to everybody else, but to yourself. Right? That you deserve to be here, that you should be here, and it's every day you get up and you keep fighting. I mean, we have had, I've had, whether it's patients that haven't done well, or grants that haven't been funded, or papers that get rejected. You have a lot of adversity, and I think I'm defined by my failures, to be honest with you. The successes, I don't remember much of those, so I can't even speak to that. But the failures are the things that I think about, and the reason that I'm here is because I fail. And the advice that I would say, and this advice has been said by others, don't be afraid of failure. It really is the greatest teacher that you have. Fail very fast, have thick skin, pick yourself up, and continue on your path.
Dr. Black, you are a surgeon scientist. You mentioned earlier that usually you can do about 80 to 100 hours a week. How do you kind of juggle that? Work with family life?
I'm gonna be honest with you, not very well. I mean, we have to be honest. We try to look for equilibrium, and everybody's like, oh, how do you balance? They talk about balance, right? This whole concept of balance, I think, is a little bit disingenuous. I mean, there is no real balance. You just do the best you can with the segments of time that you have. And I would say with work and family, I work very hard, and then the quality of time that you spend with the family is very important. That be there, be present. You may not be able to be there 20, 30, 40 hours a week. That just may not be a possibility. But when you are there, be there. And I think that that's a very important advice. That's some of the best advice that I've heard in regards to that. But to say that I have the answers to how you can be very, very successful and do all these things, I'm still looking to get more than 24 hours in a day. And I've been frustrated by my explorations in those areas. You become efficient, get done with things, when you're at home, be at home. And when you're at work, be at work.
Awesome. So you mentioned home, which I'm assuming is your family.
Sure.
Tell me a little bit more about your family.
So my wife was a transplant nurse. I met her at the University of Minnesota. She was from Minnesota. And we've been with each other for, 20 years, 21 years now. I have 3 children. I have a 3-year-old. His name is Grant. And I have a 6-year-old, Camille, and a 8-year-old, Cassie. And it's really, the children bring, a smile to your face every time you see them. I mean, it's fascinating. But what fascinates me about kids the most is their curiosity. I think a lot of adults have lost a lot of that, to be frankly honest. The kids are infinitely curious. My kids are always say, "Why, Daddy? Why?" And, I do that now with my science, speaking of, a physician scientist. And I think that their unabashed curiosity with life is something that we would do well to model. And, I just love watching them grow and develop. I mean, it's really the coolest thing.
Awesome. So you must be like your daughters and sons like hero, would you say?
Yeah, I think I am, but they're at the stage right now that I'm just dad. My daughter said, "Dad, leave me alone. I'm trying to go to sleep." Yesterday, it's just like I even look back at my parents. You take them for granted when they're there, and then when you kind of get older, you're like, "Yeah, Dad was right, Mom was right." And that's kind of where they're at so far. I'm just dad to them. I do think that they look at that, and I try not to let them down. I try to do the very best that I can to be an example to them, so that to give them the tools that they can be successful. Because it's a tough world out there, right? I mean,
absolutely. We wouldn't be these
interviews. Exactly. It's a tough world out there. So I'm hoping that I can communicate my experience and translate it in a way to give them the tools, because one day we won't be around and they're going to be left to fend for themselves, and so I want to equip them and prepare them for that.
What would you say the role of your wife in this journey? Right, long hours.
She's the rock, to be honest with you. I mean, I do a lot of things in the laboratory, and I do a lot of stuff at work, but to hold the family together, she's the glue. She's the rock. And she really is. I mean, the amount of things that she takes on, when she goes to work, or when I'm left, having to fend and for the family and do all this stuff. I mean, I have come to appreciate the work and the effort that she puts in. I mean, it's just really an incredible thing, and so I'm very grateful to that. To be honest with you, I'm not so sure that I would be as successful as I am if I didn't have a supporting wife. My wife Danielle. If I didn't have a supporting wife like that, I'm not sure if I would be where I'm at today.
Are you as excited about your successes as she is?
She's excited, but she's also said, "Yeah, it's great that you're, telling everybody to do at work, what you do at work, telling them all, giving them all these orders. Now you're at home. Go do this, go do the dishes." I do think she's very, very, very excited by what I do. But she's the one that keeps me level. She keeps me. I don't ever think I'm too important. I come home and I get put in my place pretty quickly, and so that's important. I do think she's a very down-to-earth person, and she's very humble and level-headed, and I think that's pretty neat.
Indeed it is. So we have all this cool stuff you're doing, and of course we know science and being a surgeon is a hobby, but not that hobby. What are your other hobbies outside of?
So we talked about music early on, and I love that, but my favorite hobby, the thing that I like to do the most, is I love to scuba dive. I absolutely love to scuba dive. And I learned how to scuba dive when I was a resident. Shortly after my honeymoon, we went on our honeymoon, and I saw this other couple, and they were going and scuba diving, and we were snorkeling and kind of just looking down and at the coral reefs and stuff. And I said, "Wow, it'd be cool. I want to go down there." And then I came back to where we are at Minnesota, and then I went immediately. I think for my birthday, my wife got scuba diving lessons for us. And then we learned all this stuff about scuba diving and, took all the classes and got all the certifications. And then I did an interesting type of scuba diving, because in the Midwest, there's no coral reefs. It's not tropical. So we were shipwreck diving in Lake Superior. 37 degrees, like it was some intense stuff. I mean, you do that and you learn a lot about yourself pretty quickly. And the scuba diving is just, it's amazing because it's so challenging. It's so technically hard and difficult, but you feel, you feel like an explorer. I mean, I think it's the closest thing to most of us will feel to being an astronaut, floating, in very deep water, and kind of, I mean, it's just unbelievable. So that's my hobby. And, I want to get back to doing it more. Some of the stuff that I'm doing now is taken away from my time to be able to do that. But that's the thing that I enjoy doing the most.
Awesome. Where did you go?
We went everywhere. So we did tropical diving, but most of the diving we did was in the Great Lakes. Now, the Great Lakes are interesting because, that's where a huge amount of shipwrecks were. And there's a lot of ships at the bottom of the Great Lakes. And shipwreck diving, and everything's preserved because there's no salt, and the water is very cold. So, the shipwrecks are more or less in the same condition they were. And, yeah, I mean, the things that you see down there and, kind of, working your way through a ship in pitch black darkness is kind of cool. It's kind of neat. So yeah, that's what we do. That's what we do in our free time.
That's awesome. That is pretty unique too.
Yeah, it is.
That's not really good often at all. That's great. What would you say is your most favorite quote to live by?
I have two that I think about. Dr. Charles Drew. Now, Dr. Drew was an interesting individual, and I don't know how much the audience knows about him, but he's responsible for a lot of what's happening with blood banking and things like that. And he was a surgeon, African American surgeon, and he was very influential, to a lot of us in the surgery field. And he said the excellence of performance will transcend the barriers created by man. And so what I think about when I think about that is that your work, your efforts, when they're excellent, will overcome all these obstacles that life's going to throw your way. And I think that's important. And the other one that really is important to me that I think about a lot is one that was said by Martin Luther King, that you cannot be ridden unless your back is bent. Okay? You have a right to be here. You have a right to have a seat at the table. Stand up, be proud of who you are, and don't succumb to the kind of the environmental pressure. You have every right to be here. And I think about that a lot. And I think, as African Americans, I think it would be good to think about that a lot. Absolutely.
So to the students who are watching, they just heard those amazing two quotes you live by, and they're working towards becoming a physician scientist, specifically a surgeon scientist. Like, what advice do you have for them?
My advice is have incredibly thick skin and be incredibly hard-headed and have this and just never quit. You're gonna fail, and you're gonna fail a lot. And failure's okay. Pick yourself up. You're not gonna be measured by how many times you get knocked down, but how many times you get up. And you always remember that. Get up, keep trying. The success is right around the corner. And I can tell you, my failures outnumber my successes, 10-1. And I remember each one of those times that I failed. And they've made me better. And in a way, I needed to fail because that's where growth comes from. And so we're all on this journey. You're not going to get it right all the time. You're not going to be perfect all the time. But really, perfection and excellence lies in overcoming adversity and resiliency. And I think that it's in your DNA. It's part of who you are. This whole journey of life is really this whole physician scientist career is really nothing compared to the journey of life that you have to go through every day, and our ancestors had to go through every day, and their ancestors had to go through every day. We're here because a lot of people sacrificed so that we could be here. A lot of people failed and had things happen so that we could be here, and we shouldn't quit. We should honor them by not quitting and by fighting.
Well, there you go. We are our ancestors' wildest dreams, and we need to keep pushing the envelope to getting to our own seat at the table by improving ourselves. Thank you so much, Dr. Black, for sharing your time.
My pleasure.
And all those great gems with us. I think our audience is going to really, really love this segment because I did.
My pleasure. Thank you so much.
Thank you.
AABPS has created a foundation that is integral and it's incredibly important for African American clinician scientists. It has created a foundation of support for developing scientists, and I encourage you to join AABPS today.